Webinar in our 2021 series. My name is Brian Harper and I'm the Director of Communications at DAN. We are glad you could join us this evening. Go ahead and post in the chat and let us know where you are tuning in from. And as with all of our webinars, we'll be doing a Q&A session at the end of this one, so please post your questions in the chat. We'll be keeping an eye on it, so go ahead and post them as they come to you. Note that if you're watching this on the events page of dan.org, you won't be able to post questions, so in that case, you can look at the bottom left corner of the embedded video player, click the YouTube logo, and go to Dan's YouTube page where you'll be able to post questions in the chat. All right, let's introduce our speakers for tonight. Matthias Nichetto, MD, is the Director of Medical Services at DAN, where he has worked since 2006. He is co-director of the DAN UHMS Continuing Medical Education Program and a faculty member of several national and international diving medicine courses and programs. He became a dive instructor during medical school, which led him to complete a 3-year clinical and research fellowship in hyperbaric and diving medicine. Next, Camilo Saraiva, MD, MBA, is the Assistant Director of Medical Services at DAN. He is board certified in radiation oncology and hyperbaric medicine, and is a former director of the Brazilian Hyperbaric Medical Society. Dr. Saraiva is a member of the Undersea and Hyperbaric Medical Society and the American College of Healthcare Executives. A former cave diver, he has been a dive master since 2000. James Chimiak, MD, is the Chief Medical Officer at DAN and has been working with the organization since 1983. He is board certified in anesthesiology, pain management, and hyperbaric medicine. Dr. Chimiak holds U.S. Navy qualifications in surface warfare special operations, mixed gas salvage, undersea medicine, flight surgery, and saturation diving. Tonight, they will be presenting COVID-19 and Diving June 2021 update.
So, thanks everybody. Thank you for joining us. Like Brian was saying, we're presenting you an update on COVID-19 and diving. So it's been 1.5 years, roughly, since the WHO declared the pandemic, and we have learned a lot about COVID and diving and COVID in general over the course of these last months. I think this is the 3rd webinar or 4th we do about COVID and diving.
Right.
So let's see if we can bring some light into this madness. So I'm going to be talking about the status of the pandemic, our global path to immunity. We have to keep on preventing spread, and eventually how SARS-CoV-2 affects, how we know it affects body systems. So this is our journey in the US. As you can see, we have been through some rough times, particularly by the end of the year. What we see here, of course, is the number of cases reported per day. And I want to emphasize reported per day because, you know, when you think about going diving elsewhere, you will probably want to look into the number of cases that the country reports, but that usually doesn't necessarily tell the whole story. You need to be also looking into the deaths, the fatalities reported. That is usually a better indicator as to what is going on in that particular country in that particular time. So here is the number of fatalities reported in the US over the course of the pandemic. Again, initially a very big spike, and then we started to gradually think we were taking control over it. And then again, by the end of the year, we had a pretty rough time. And finally, by the end of the year, again, we started vaccination, and that is what eventually made a significant dent into the pandemic for the US. Remember, no infectious disease has ever been eradicated just by herd immunity. It's vaccinations what eventually took some serious diseases over the course of our mankind into extinction, right? So what we see here is COVID around the world. Now, this image, although it shows very dark areas around the world, this is a snapshot that superimposes time into one snapshot, right into one image. So you see in the US very dark colors, which is usually indicative of a serious pandemic effect. But right now, that doesn't show what is happening as of today. So if we look into different countries and what they're reporting, we see some countries seem to be doing better than others, right? We see that the number of cases reported in Brazil is remaining high, and they are having a bad time. They usually have about 87,000 cases, new cases reported a day. India has been through some rough times, and they seem to be doing better now. They somehow either report great effects or things are actually getting better every day, right? Russia, Iran, the UK, US, well, we see interesting numbers in some countries, mainly in China. This is, for some, is no less than arguable what those numbers mean, but anyway, it is what it is. So again, we always have to keep in mind when you're thinking, particularly for us in the US, where we feel we're somehow returning to normalcy and we feel like we can't hold it anymore and we want to go diving, remember, the situation we are fortunate to live here is not necessarily what is happening elsewhere. So when you're thinking about going diving somewhere else, try to look into this. What are the number of cases reported daily? What are the number of fatalities before you make a decision, right? And also, what is the path to immunity for each one of those countries? In the US, we seem to be doing fairly good. I mean, we had some fantastic numbers around March, where on some days we were able to vaccinate 4.5 million people per day. That is absolutely impressive. We're very lucky, and we should be proud of what we've been doing with this pandemic. So what happens in the rest of the world? As we can see here, the US is about 50% of the people seem to be vaccinated now, about 40-something% in Canada. When you look into other countries, some countries in the Caribbean, for instance, where we tend to go diving a lot, some countries are doing fine, some countries are doing fantastically well, and some others not so much. So let's zoom into some of those countries. Say, in Mexico, for instance, 15% of the population have been vaccinated. That is 2% or 3% in Honduras, 11% in Belize. Some countries like Cayman, for instance, they seem to be doing fantastically well in terms of vaccinations. Same thing for Turks and Caicos, about 50%. The ABCs, the Netherlands Antilles, about 55% of the population seems to be vaccinated. And when you go to the Windward Islands, in the northern part, about 50%, and as you go south, the vaccination rates become less and less significant. What about Southeast Asia? Well, they still have a long way to go. Some countries in Southeast Asia, like the Maldives, they seem to be doing fairly well. Actually, 66% is impressive. These are small countries anyway, so it's fairly easy to vaccinate population there. Indonesia, only 6 or 7% of the population are vaccinated. So the situation is not anywhere near what it is in the US. Some countries like Papua New Guinea, they're having a hard time with vaccination rates. And although you may say, well, Australia, New Zealand, they have low vaccination rates, keep in mind that these countries, the strategy was a little bit different. They're big islands, and they isolated themselves. So vaccination rates are not great, but the number of cases they have is so low that the strategy is to wait until they can get a hold of vaccines, and while they remain there, isolated in an island, they seem to be doing fine with it. So we know we need about 70 to 85% of people vaccinated to return to normalcy, and right now it's only 17% of the world that has been vaccinated. So we still have to continue to minimize our efforts to contain the spread. So transmission. By now we do know that this seems to be risky. So how do we contain this? Remember that when we're trying to contain the virus spread with a face mask, we're not trying to contain the virus itself. If you think about the size of a virus, and you compare it to the size of a Volkswagen, the coronavirus is about the size of a rat. It's a tiny, tiny structure compared to a red blood cell. So we're not trying to hold the virus. We're trying to hold what transmits the virus, which are the fluge droplets, right? Droplets we release with respiration, with sneezing, with coughing, etc. So the size of a virus compared to the size of a droplet is many, and probably hundreds, if not thousands of times smaller. So again, we're not trying to hold the virus, we're trying to contain the droplets. So when we breathe, when we sneeze, and actually when we talk, we know we release those droplets, and that's why we always insisted in keeping those 6 feet apart or 2 meters between people, the social distancing. And we also know that it's not just the big droplets. Those, they fall very close to where you are, but the aerosolizations, they seem to be to float or to be spread farther apart. So this is an interesting study where they showed that depending on the environmental conditions, those 6 feet or those 2 meters apart, they may not be sufficient. What they showed is that in environments where the relative humidity is much higher, say 90%, the droplets, they seem to go around 150 times farther apart than with drier environments. So this is important, right? Where we go diving, usually humidity is high. So this might be a good reason to try to change or be more proactive in trying to contain the spreads by optimizing ventilation and indoor humidity. So we know that masks, they're good to prevent the spread. The surgical masks or homemade double-layered stitched masks, they are highly effective in, again, preventing the spread, not necessarily protecting us. So the surgical mask doesn't do much to protect us from breathing something. They're really good at trying to catch what we breathe. And by everybody catching what we breathe, we're protecting ourselves globally. So these masks, they don't do a great job in filtering what you breathe. They are good for catching droplets. They prevent the spread. Now the N95s, the one you see here with this valve, they're great to filter what you breathe, but they don't do much with catching droplets. So if you have one of those with a valve, I would say they're rather selfish, right? You're filtering what you breathe, but you're not doing anything to protect others. And finally, we have the N95s. These are great to filter what you breathe, so they protect you, and they're great to catch droplets. But those are usually more expensive, they're harder to breathe, and they're reserved for healthcare personnel. So what about the use of face shields? We have seen many things, and sometimes we still see them today. So what are they good for? We see people using this almost on a daily basis, and it's worth saying something about this. So as you can see here, this guy breathing with a face shield and nothing else, you can clearly see that he's not containing what he's breathing out, right? And droplets, they don't travel like photons. So that face shield is only protecting you from catching a spit, but does nothing to prevent you from breathing what is out there. So if you want to use a face shield, the right way to use a face shield is not this, it's actually in combination with a face mask. So please, when you see someone wearing a face shield, well, try to approach them and explain to them that this is not the right way to use them. So remember back then, a few months ago, when we were using and going crazy every time we were going to the supermarket, the grocery store, and we were wiping things with bleach every day. Well, now we didn't change, the scientific community didn't change their mind. New evidence shows up, and now we know this seems to no longer be necessary. If you want to continue doing it, great. But again, new evidence showed up. It's not that scientists change their mind. We adapt as things evolve. So here we see the time course of the SARS-CoV-2 viral shed. So we know when we were infected, we see there on week -2. So on week 1 is when we do the nasal swab and we start having symptoms. But it's important to know that you're actually shedding virus between weeks -1 to week +2. That is why we ended up in a pandemic. Long before someone has symptoms, they are spreading viruses all around. So even though you may feel fine, it is important for you to wear a mask to protect others. So what are the concerns about COVID and diving? You know, all clinicians, they always say that there are no diseases, but patients with a disease. Each case is its own universe and must be addressed individually. And when we think and we consider that this is still a new disease, there are no definitive guidelines yet. So important considerations that we should always take care about is, what is the patient's past medical history? What are the demands of the type of diving he is intending to do? What are the long-term expectations? And what are the long-term medical follow-ups? So in terms of the demand, what I wanted to say is that you can imagine it's not the same thing when someone has had a mild case of COVID, when they may still have some residual symptoms, and the only diving they do is in shallow tropical environments, very predictable. When you put that into consideration and you say, well, what about if I want to do technical diving, say scapa flow, well, that is a completely different environment. So your margin for error is far less. So the natural history of COVID is still unveiling, and the chronic phase, what is known as the COVID long haulers, has yet to be fully described and understood. And we knew from early on that this is not just a pulmonary disease. We know it affects the lungs, it affects the heart, and it also affects your blood, particularly causing or increasing the chances of blood clots. So those systems that are affected, they are affected for a reason. You can see there on the top left side of your screen, you see the animation of the virus, right? And you see the spikes, the spike protein. So the spike protein is actually looking for a protein that we have in our system, which is the AC2 protein. And that protein is in those body systems. So that is why the virus affects those systems primarily. So what you see here on your left is the lung of someone normal, right? So trust me, that is a fairly nice X-rays of lungs. Now you don't need to be a doctor to realize that what you see on the right doesn't look anywhere near what you see on the left. So that is someone with a COVID lung. That is someone with a significant COVID infection. So pulmonary concerns in diving are where and have always been what we fear the most. So this is a respiratory tract is the primary mechanism of infection, morbidity, and mortality. It's a viral pneumonia that can range from very mild to severe. It is often bilateral, and it causes what scientists call a cytokine storm. Cytokines are pro-inflammatory mediators. So you have such an inflammatory process that it's actually the inflammatory process what is causing most of the damage itself. And what we see on the lungs are what we described there, the ground glass opacities, the crazy paving pattern, that is the description of these findings, and the consolidations of certain specific areas of your lungs that are filled with pus, right? What you see here is a color-enhanced scanning electron micrograph. I don't know if you can see those structures there. That is the capillary bed in the alveoli, and inside the capillary bed you can see the red blood cells going one by one. So this is a very, very delicate structure, very tiny, very fragile. Here this is a histology preparation of a normal lung. You see the terminal bronchioles, the respiratory bronchioles, and finally the alveoli. If we zoom in into those walls, we see a particular cell, those type 2 pneumonocytes and type 1. This is what the virus is aiming for. And when we have an inflammatory process and we see that on the capillary, this is where gases, oxygen and CO2, they need to go in and out, and eventually nitrogen too, right, for us divers. And when you have an inflammatory process here and this becomes thicker, well, perfusion is impaired, oxygenation is impaired, and you are in respiratory distress. What you see on the left, that is a normal lung. What you see on the right, that is someone with an acute respiratory distress syndrome. All the alveoli are full with liquid and with inflammatory cells. So here is a more lay people friendly image. Again, what we see on the left, that is the way an alveoli should look, and the distance between the alveoli and the capillaries and how we exchange gases. And what you see on the right, that is something that is really, the technical term would be messed up, right? Where we have all fluid in the alveoli, and of course, your oxygenation is impaired, your respiration is impaired, labor breathing, and everything tends to collapse. So, radiological findings, they tend to improve within 3 or 4 weeks. The resolution of inflammatory process might lead to residual changes. Technically, the lung is scarring, and those scars are what we're concerned about. How would those scars affect your breathing, affect the mechanics of ventilation, and eventually affect gas exchange and gas escaping when we're ascending from depth, right? So this can cause decreased lung compliance, scarring, fibrosis, and structural anomalies like air trapping. We all know that air trapping while diving is dangerous. So overall, the pulmonary function might be impaired, and we know diving imposes some unique challenges and demands. So can mobilizing cold and dry air cause a reactive airway and bronchospasm, and that lead to gas trapping? Is mobilizing a denser gas through a scuba regulator this increased breathing resistance, does that pose any new challenges? What about the massive barometric changes we have while diving? What about the relative hypervolemia, the blood shifts that happen while diving that imposes another challenge on the lungs? How can we manage that when we have a lung that is recuperating and trying to get over from it? So the risk of pulmonary trauma and decreased exercise tolerance is what we fear the most in pulmonary sequelae. What about the cardiovascular concerns in diving? We know that cardiovascular is a secondary damage. The cardiac impact of COVID was recognized very early on, and we know now that there is no typical cardiovascular manifestation. Many different people, they may have different markers and different manifestations of cardiovascular impairment. So diving, we know it poses some unique challenges and demands. What about immersion physiology? Again, we're talking about this blood shifts, and this causes a massive or significant cardiopulmonary challenge. So we know that a thorough cardiac evaluation might be necessary in some patients. And the thromboembolic concerns in diving, we need to know more about this. We know that COVID can induce a hypercoagulable state, that is clot forming. This is usually in the acute phase and can lead to multiple life-threatening complications. Now the incidence of venous thromboembolism is significant, but the true incidence is unknown. And the chronic effects are also unknown. So it seems unlikely that the hypercoagulable state would remain past the acute phase, but we don't know yet. So the concern or the risk here is, the questions that we still need an answer for is, can decompression stress that we know can activate platelets and complement system, can this make you more prone to having a hypercoagulable state? So can normal hemostasis is the normal systems and body systems that we have to keep blood where it should be in the blood vessels. And so can normal hemostasis cope with adequate decompression procedures? Could we become more susceptible to these events? We still don't know. So we definitely need more research about that. So, Camilo, I'll let you continue with this.
Great, thank you. So let's talk a little bit about the vaccines around the world, potential treatments for COVID-19 and diving after vaccination. So we all know this virus by now, we are familiar with this image, but one thing that we have to keep in mind is the red structure shown here, which is the so-called spike protein. If we think about this spike protein, this is a protein that is expressed in the surface of the virus, and it's the key to access our cells. So this is what the virus uses to get entrance to our cells and to do the damage that the virus does. So if we think about these proteins in a side view, these proteins, they look like microscopic tulip. So on the top view, if we see this tulip from the top, we see that there are several different parts that form this spike protein. And the separation between these parts, or the more open this tulip is, the worse is the effect. The likelihood of infection is greater. So on the top view, when we hear about the variants, the most important thing that changes with variants is exactly the degree of these protomers, these parts, the degree of separation that they have. The more separate, the more infectious the virus is. We have to acknowledge that this is very tough times, and very exceptional efforts were put in this disease. If we compare to past diseases and past pandemics that we had more than almost 200 years to isolate measles, 158 years to isolate polio, 11 years for mumps, and just 2 weeks to isolate the full genome sequencing of SARS-CoV-2. So it's really, we're really moving forward in a pace that we never seen before in science. Just so you know, we have at this moment, we have approved by the FDA here in the US, we have 9 trials, 3 for vaccines, 5 for treatments, and 1 for antiviral therapy. If we think globally, we have almost 1,600 trials around the globe for vaccines, treatments, and alternative therapies or antiviral therapies for this disease. If we think in trials for therapies, for treatments, out of the 5 here in the US, we have 542 globally. Or the opposite, right? 442, 542, 5 here in the US. Out of the 102 vaccines around the globe, we have 3 approved here by the FDA. And the most important thing with the vaccines are their way of working. We have more traditional vaccines, which the mechanism we already use for other diseases, like this first one. We have the virus, a part of the coronavirus embedded in a known and harmless virus that enters our cells, produce the spike proteins, and we generate an immune response to it. The most discussed lately type of vaccine are the new discovery and the first time we're using it in mass scale, which is the mRNA vaccines, where the mRNA of the virus is embedded into a nanoparticle that links to our cells and put this mRNA inside our cells. The mRNA is like a blueprint for the virus proteins, and it uses the machinery of our cells to produce this protein and express this protein in our cells. So just the spike protein, and this is recognized by our immune system and produce response, and if and when we get in contact with the real virus in the future, our immune system knows how to respond and to destroy this virus. And the third and final type of vaccine that we're going to discuss tonight is the inactivated virus. So you get the full SARS-CoV virus and you change things on it in a way that it will not cause the disease, but it will infect the person enough to cause immune response. So, going to vaccination and diving. No diving for 2 days after any post-vaccine symptom, including local arm pain. So you took the vaccine in your arm, you're feeling pain in your arm, until this pain goes away and you have no other symptoms and you have 2 days of this, you should not be diving. It's better for you not to be diving. Of course, if you can wait for 2 weeks after the last dose of your vaccine, you'll be more protected and you're going to be safer to transmit and to get infected by the COVID. Always consult your physician, the CDC and FDA recommendations, and as a reminder, never dive if you are unwell. If you are unwell or unfit, no matter if it's for COVID or any other matter, you should not dive. I'm putting here the remaining of the 10 most advanced vaccines that we have in the world in terms of licenses and certifications and protocols, all the studies done. I'm just browsing through. Please go back to the video when you want to see. If you're not here from the US, you don't have the 3 options that we have here. Take a look at this video, pause the video, take a look at the charts here. They have a lot of information. so you can reference this later. As I said, just browsing through, so you can come back to the video later and take a look at it. Now, Dr. Chimiak is going to continue.
Thank you, Camilo. So far, we've discussed some aspects of COVID-19, and I think trying to get this all done in 1 hour is quite a feat in itself. So my part of the webinar is going to talk about returning to COVID after diving. To also talk about Dan's COVID study that we've put together and have got over 1,000 participants and closed it out at this point. Well, first, as you know, this is a moving target. Anybody that thinks otherwise obviously is not following it. The information is coming out at just a tremendous exponential pace. Good research is now coming forward. When initially we had a lot that came over the internet, a lot of things that weren't refereed or peer-reviewed came out. So what Dan did is they sponsored a workshop earlier this month in conjunction with the UHMS at the annual scientific meeting. At that, we were able to assemble some of the world's experts in diving medicine that are also intensivists, anesthesiologists, emergency room doctors, scientists, and put together what we felt were very important aspects of the COVID-19 infection as it applied to divers. Here's the actual schedule and the participants in that workshop. They're the presenters for that workshop, and quite a few things were covered. As I said, this is rather new information. Some of the things that were covered were the effects of hospitalization on a diver, some of the post-ICU syndromes that occur, discussing some of the cost-effective investigations that have to be done. Because you remember, if we have investigations that need to be done, they also need to be effective and cost-effective because of the sheer numbers of people that have been infected with COVID-19. We looked over some respiratory aspects of COVID-19. There is a range of things that Dr. Nichetto went over expertly, talking about some of the effects on the lung itself. You can have fibrosis. You can find blebs and small bullae that are in the lungs coincidental to the COVID infection or actually caused by them. A very, very important issue, because as you study and you look for some of these things, some of these rather small findings could be quite detrimental to a diving career. Pneumothorax has been seen. Pulmonary edema, as has been talked earlier, it can be a function of the infection and certainly plague a diver at depth. And of course, shunting. That is one of the things that we need to look at and certainly understand. The cardiac aspects are what's been truly amazing. The cardiologists have got together and really hammered and looked at some of the problems of a returning athlete. And this was a challenge in the fall sports season to get college athletes and professional sports back on track. And they did a good job of going through some of the initial data that looked quite distressing, 80% problems. And when they did the actual analysis, they knocked it down to maybe less than 1% issues that they were seeing. And the problems they were looking at were quite serious. There were rhythm changes, there were myocarditis, and there was actual heart failure that was suspected or feared would be one of the problems. And so they did a good job. We actually had one of the members of the team, Dr. Martinez, along with Dr. Lees, Phelan, Begish. Those are the ones that I communicated with. But there was a whole host of these gentlemen that came up with some very good instructions and algorithms of how to get people back to play, how to get college athletes, elite athletes back, all the way up to masters athletes, and looked at the whole idea of, can these individuals get back to play and get back to play safely? So we used that. But we also had to realize, and that's one of the reasons for the workshop, is the environment in which divers are going to be exposed in. So that made a bit of a complication, so we had to extrapolate from what some of the things they saw. We also looked at some of the problems with neuropsych issues that have kind of been talked about, but didn't get quite the footing that the cardiopulmonary aspects did. And we see things like brain fog, difficulty with executive functioning, memory, depression, again, PTSD has been raised also. But these could affect divers. These could affect you at depth. And then in conjunction with nitrogen narcosis, it's something we have to ask about. It's something we have to look at when we go ahead and do our return to diving. And one of the things that comes up a lot is shortness of breath and fatigue, and that's one of the big carryovers, or one of the things in the recovery periods and even in the long haulers. And we even had a separate discussion on that itself. How do we go ahead and look about someone who has shortness of breath and fatigue? And that's an interesting problem, because it can be just deconditioning. We haven't been exercising for the last year and a half, and perhaps that could be one of the issues. Psychological issues, of course. But more important is the cardiopulmonary aspect. So oftentimes we have to go ahead and do deeper investigations before that individual goes back to diving. We had some interesting discussions on endothelial impact, because of the fact that we have the ACE2 receptors in various tissues. The endothelium, or the lining of our vascular system, is filled with these receptors, and the impact that the virus has on that can be potentially a problem. And we elucidated a bit before as far as what does that mean as far as these DVTs, these blood clots, these pulmonary embolism events that may occur. We were concerned about that. And it can actually be a factor in your travel to and from those long travel, sitting in a sitting position, dehydrated. So please focus on that too, as far as if you get up often, walk the halls, the aisles of the aircraft, maintain hydration. And it was even discussed whether an aspirin may be appropriate for those trips and for those individuals that are post-COVID. We talked about some algorithms, and I'll get into some of those in the discussion here today. And then finally, our discussion about our what we call the Draco Study, the didnt study with the 1,000 divers. So going back to what we've distilled, this is our distillation of the RSTC recommendations, and just basically gives us some sound, some sound choices as far as as you age, getting your physical as you get from 45 to 65, there seems to be an increase in the amount of problems that individuals will have. And we have recommendations, and as you have more and more medical conditions, certainly you should see the doctor, or just go through the questionnaire and see if you need to go see someone. The RSTC form has been very well engineered to do that. I wanted mainly to highlight the acute illness, and that's COVID-19, and that prompts you to go ahead and see your doc, and that's something we'll talk about here with the Draco study that a little distressing. So the 30,000-foot view, essentially we're talking about the two groups, and you have to make that distinction. Those that are asymptomatic, those that have full exercise capacity, now going back to diving. Now that is very conducive or fits very nicely into different types of algorithms. But the big part of that is going to be that recovery rehabilitation phase. And that's the variable part of this particular group. And for someone who has a mild infection, it tends to be about in the 2 to 4 week time frame. It's the ones that have the more mild cases of COVID-19. The more severe, the moderate, the severe cases, they can be 2 to 3 months. And some, of course, with the long COVID, will not go back to diving until that resolves. And that seems to be the split as how it affects the pulmonary structure, the pneumonia, the deep respiratory tract infections. And in fact, I'm an anesthesiologist, and to get folks back into the OR, we look at such things as when is it safe for someone post-COVID. And we find it's kind of interesting how some of these intersect, and we look at 6 to 8 weeks being a period for a severe pneumonia or a deep lower tract respiratory infection. Then there's the other group, and that's the symptomatic group. That's the group with the decreased exercise capacity, or has, in the course of their illness, had some abnormal labs. And those are going to be the ones that you're going to have to study. Those are the ones that are going to be restricted from diving, restricted from activity even, because if we're concerned about some of these things, either with lung or heart, we need to investigate those. And sometimes that may entail getting a specialty consultation, such as a cardiologist or a pulmonologist. you saw it in previous, I think Camilo had it in his, is please do not dive if you feel unwell or unfit. And this goes COVID-19 or anything, but when you don't feel well, please don't dive. It only can make things worse. So in this case, if in the course of diving, or if you're planning to dive, if you don't feel well, don't dive. Bring them to your physician's attention, and you may need some additional workup or studies. Our friends and colleagues over at the University of California in San Diego put together a fairly nice paper and algorithm that they use in their dive medicine clinic. And you can see that they broke this down into mild cases, moderate cases, severe cases. And as a result, they look at and typify them in that type of algorithm. And what you see here is, you see the moderate and severe cases seem to be more associated with the hypoxemia as opposed to mild or even asymptomatic. Asymptomatic being the ones that test positive and then have a positive test that shows that they may have had COVID. And you see that there seems to be a bit of a split there, and some of the algorithms will certainly entertain that and work that into the algorithm as a result. The sicker you are, obviously, the more studies that probably are needed to see if you can return to diving. The good thing, and this is just one of the early studies that came out, is that fortunately, mild, moderate, asymptomatic seem to be the more predominant cases rather than the more severe cases that are oftentimes highlighted and sometimes catches attention, say in media, and therefore maybe grabbed a lot of the headlines or swayed some of the opinions early on. And all of us are aware of some of those messages that were put on the internet that, if you had COVID, you couldn't go back to diving. If you had COVID, you couldn't even join the military. At one point, these were the things that were actually being put out there. And of course, these have all been walked back quite a bit or totally eliminated. As I said, this is the algorithm that they generated from just looking at the different kinds of severity of cases. And you can again see that some of the recommendations, looking at both the cardiac and the pulmonary aspects of the disease, and looking at, you can see that this advances with the more severity of the case, and you start getting into looking at some of the cardiac aspects. This initially was quite an important part of that role, and even in some of the mild or moderate cases, as far as getting echocardiogram, there were even calls for what they call a cardiac MRI, which were seen as an extremely sensitive test that was picking up things that were either false positives or very small events that were not clinically relevant. And so we're seeing that the use of some of these tests are predicated on patient and the severity that they had while they were hospitalized. As I've said, things happen so quickly. This is brand new, so forgive me as I work this through for you, but this, just this week, in fact, as the Navy works through a very practical approach. They have an incredibly good team up there. The Navy is very fortunate. They have a captain, a doctor's Tripp, Regis, and Dirks up there, all different. Infectious ones, a pulmonary intensivist, the other's occupational health. They put together an incredibly good algorithm in which they looked at divers going back to diving after COVID infection, and they looked at those with very mild infections. They did a very intelligent way of looking at it, and as you can see, many will go through this algorithm and return to diving quite easily with some questions and investigation as far as recovery from that mild episode or a positive test. And what they do is they ramp up based on that moderate severity range and add additional tests as you move along this segment of the algorithm. They put it back down as if the results are normal. They're bringing them back to the doc, to the primary doc, to their dive medical physician. They'll take a look and get that global look at the patient one last time, and hopefully all becomes normal. Specialists have all weighed in and found a negative result, puts that person back to diving. Of course, those that still have abnormal findings or things that are coming up on some of the testing, they will not return to diving, obviously. And what they do, and you'll see this in most of the algorithms, you'll see this in most of the advice that's given, is the need to do exercise testing. And we found that once you put the load on that individual, it tells us quite a bit about that individual. And so the Navy has excellent docs all over. There's this ability to do this for us, but in some remote places, they may not have access to a doc or a pulmonologist. So the Navy actually put together a fairly interesting and useful exercise screening test protocol. And in that test protocol, we're seeing the idea of putting that person at rest and then looking at their oxygen saturation at rest. And they picked 96% as being something that needed referral, needed more investigation. And those could include, the PFTs, the DLCO, they're specialized tests to look for the function of the lung and are very helpful and even going on for a more advanced chest CT needed. Then, if they pass that aspect of it, they exercise them. They put them out on an exercise bike. They have them run for about 10 minutes or so, and then they get their heart rates up to about 120, 130 range, and then they look at their exercise or their oxygen saturation. And they use this with a simple pulse oximeter. We've all probably seen them. They clip to the finger. They give you a measure of oxygen saturation in the blood. And they find if they get a measure of 88% or lower, of course, these go on for investigation. And they also include, if it's 5% lower than their baseline, they also send investigation. They also look at these individuals, how fast they return to their baseline oxygen saturation and their heart rate after they're allowed to rest after this stress. And they've effectively employed this, and it's seen at this point working out quite well for the Navy. So, return to diving. And that's, I think, is probably what we're all talking about. And the overall view of going back to diving requires these steps. And algorithms and the testing, the physicians, the use of the RSTC form of getting you back to diving, the idea of the return to diving that Dan has on its website, looking at the mnemonic theft, as far as preparing to get back to diving. But as far as you going, as far as your health getting back to diving, it's these phases here. And we talk about the pre-infectious stage, what that is, taking care of your medical conditions, making sure everything, your blood pressure, diabetes, all is in the best possible condition it is. And getting yourself in a good, here it is again, physical fitness. Get yourself in a good aerobic, physically fit state. Of course, quit smoking. But one of the big ones is losing weight. We have noticed that in COVID specifically, that if your BMI is above 23%, you're seeing a linear rise in the severity of your COVID infection. So losing that weight is also beneficial for preventing the infection. Prevention, we've talked about risk mitigation, whether you're, again, Dr. Nisheta did a good job showing some of the risk mitigation techniques that were employed. Dr. Saraiva with the vaccines are probably the dominant, most important as we try to prevent this illness. And those measures are important. But once you get sick, there's the treatment, the acute phase, the use of medications. Whether they're going to modify the outcomes, we are not sure. This is the early phase of how these things are how they're going to mitigate those terrible things we talked about earlier about pulmonary and cardiac, whether some of those treatments are helpful. The recovery period is very important. During this period of time, this recovery rehab period, you're going to be working with your doctor. If you had a severe enough infection, your exercise program may be very graded and very controlled. A lot of programs now are opening up. Long COVID clinics are opening where you may have a cardiologist or pulmonologist working with you as you advance your exercise program to help you get back, but most importantly, to make sure nothing untoward happens to you during your rehabilitation phase. Once we get you to a good recovery, the asymptomatic phase, as I call it, that gets you to, at or above your previous exercise level, everything we've investigated any abnormal labs, then you're going to be finally going to your dive medical physician and getting your clearance for diving. And he or she may go and order some additional specific testing, but at that point, that's when you'll be entering your dive program. And what I recommend is when you start this, look at going at it slow. And all of us who are receiving calls there on the Dan hotline, we see and it's natural to go back to, a very remote, beautiful place and go ahead and try to dive in that place right off the get-go. But you should probably focus on a more conservative approach, one in which you're observed by your dive team and you're getting your refresher, you're getting reacquainting with your gear, and any problems that are coming, don't do the normal thing. A lot of folks overlook it. This is very important. If you're having something that's unusual that's happening to you while you're diving, you should stop and then see your doctor. Go back and get that reevaluated. And then finally, when this is concluded and you're doing some uneventful dives, you're refreshed, you're familiar with your equipment, you're trained, you looked at that spot that you're going to, like we were talking about, some places may be under some pressure. You decide where you're going to go traveling, it's unrestricted. Then you can go ahead and start to begin to return to whatever types of diving that you do. And if we had more time, we could talk about specific diving, and things of that nature. But the one I like to just express the need to go ahead is breath hold diving, because of the fact that you're sitting on that hypoxic, elevated carbon dioxide levels that may occur. You probably need to ensure that you may even increase that level or that surveillance. Your docs may increase their level of observation or investigation with you before returning to that, particularly if you're going back to a competitive breath hold diving scenario or aggressive spearfishing. The Draco study we started that last. We knew that this was probably going to be a very important aspect. We took all divers, over 1,000 divers from all severities, from asymptomatic to those that have been hospitalized, that were on ventilators for weeks at a time, and looked and tracked how they have been doing coming back to diving. And it's been an eye-opener in that those that we're starting to see some that have gone through and recovered. We're seeing those that are in that slot. About 70% looks like they're returning to diving, and we're watching them and seeing how they're doing with their dives. There's 0.5, about 0.5% that are talking about that they may not return to diving. Not quite sure. We haven't broke open the actual reason for that, but we'll be following that closely. What we did find that, and this is the distressing part, is a third went and got a fitness to dive evaluation, like we talked about earlier, and under 50% are intending to go back without such an evaluation, and that's probably not prudent, it's definitely not prudent, and something you probably should do and discuss that with your dive medical physician. It's something we wanted to bring up. We wanted to thank those divers. And maybe whoever they may be tuning in now is you've probably had me calling you at all, at various times and getting some really detailed information off of your experiences, and has been very successful. And I do appreciate your time or have been doing that, and hope to have some fairly good information for that. As I said, this is a moving target, so to speak. We're moving into some of the better investigations and more information that can help us long term and advise us even better. And some of these algorithms will probably be modified with time as we get more information about long term, the long hauler, and that sort of thing. So at this point, I don't want to go any farther. We're going to open it to any questions, and we'd be happy to try to answer. And if we don't, we'll certainly let you know.
Yes, indeed. Thank you to all three of you for taking the time to put this presentation together. And thank you to all of you who are tuning in to watch this evening. We really appreciate the support. And without Dan members, we would not be able to do this sort of educational outreach. So we want to thank you in particular. So yes, let's go over to the questions. All right, one that we've had is people who've heard about brain fog, and maybe that's associated with the long haul COVID you mentioned, or post-acute COVID syndrome. Would that be a problem with diving?
Yeah, and that was one of the things one of the aspects that were brought up at the workshop specifically, and looking at it, is that a direct effect to the brain itself. As you know from previous slides, that there are problems with COVID affecting the brain. So is it a direct effect on the brain? Now, how does it affect the diver? Is executive function, memory, things of that nature that are important as we do dive. That you know, the ability to get out of a tight fix, to be able to do a job when you're underwater. So the idea, if you have it, it should not be something that's discarded. It should be something that's investigated. It may entail some further investigation, some more detailed mental status examinations to examine, see where you are and how impaired you are with brain fog. Certainly, you're going to be exposed to elevated levels of nitrogen that may cause nitrogen narcosis, whether that's additive or synergistic, also has to be brought into this.
That's key, right? I mean, when you're underwater, you know you will be, to a degree, somehow impaired. It's important to take that into consideration. You don't want to start impaired, and that lead you to trouble, right?
Sure. All right. Here's another question we've gotten. Should we be doing more testing of patients than what is already being done? I guess more detailed or thorough testing.
That's a great question, and that's probably the one that needs to be answered as we go forward. The more testing you do, the more chances you'll find incidental findings that have maybe nothing to do with the COVID-19 infection. It could be a tiny bleb that may result in disqualification. It could be some finding, some fibrotic change in the lung that was there before and consequently leads to disqualification. And that's just the incidental findings. But more importantly is the false positives that can be generated, because there's no perfect test. If you investigate into a population where there is no disease, the benefit of that test just plunges almost to zero. It's abysmal if you're testing when it's inappropriate to do so. And so when talking with some of the specialists, the cardiologists, the pulmonologists, a big part of their role is unraveling some of these abnormal tests that are borderline abnormal, borderline normal, and having to unravel, was this a problem or not? And that's the difficulty with just doing blanket tests. And if you do the more tests and the more they're incorrect, the more chance that you're going to go down that road and have to do some additional tests. And some tests can actually be a bit harmful to perform, but that's probably one of the big issues, is to appropriately do it. Cost effectiveness. You also got to remember how many people are affected with COVID-19, and the idea that, are you going to test everyone with? At one point, there was a cardiac MRI would be an example, and it's absolutely no. And the cardiologist did a very good study, and looked at this very closely and said, no, that's not an indicated screening test as an example of trying to decrease that testing burden that is ineffective.
And it's possible that at the beginning we might be over-testing people, right? This is normal. Actually, to a degree, that is fine. You want to maybe at the beginning, and we still don't know, because this is still unveiling. We have a lot of people that still need to go through this. And as we go through this, we will probably overstudy people. And then within maybe a couple of years, we'll feel more comfortable to what is necessary and what wasn't necessary. And everything is going to be, hopefully, more sane, as opposed to all the madness that we've been.
That's a great point. Like, the athletes got a whole battery of tests, and from that was actually beneficial in that early goings, that we were able to look at those tests and see which ones were beneficial, which ones yielded pathology that we needed to act upon. So that's a great point.
But I think it's important also for people to know that if you don't get the same studies that somebody else has gotten, that doesn't mean that you're not being studied well. Trust your doctor. To a degree, they know what they're looking for. If you can explain them what your needs are as a diver, great. And if you can't, by all means, come to us. We'll be happy to talk with them and explain to them, give them our 2 cents as to what we know you may need as a diver.
That's another great point, because of the fact that you may have multiple medical conditions. You might be an older diver.
Yeah.
So they may put you into an algorithm or their train of thought of actually looking and adding an additional test that say another person without those factors may not receive.
What we're saying, right? Every patient is its own universe, and we don't talk about the disease, but the patient with the disease. So again, what they do to one diver may not necessarily be necessary to somebody else.
All right. And in terms of returning to diving after having a COVID infection, do you really think that COVID is any different from any other severe viral pneumonia?
Yeah, I think that's a good valid question, and it comes up. And a viral pneumonia is serious. I mean, the problem is you don't gaff it off, and that was some of the I've looked at either being an Armageddon, apocalyptic event that was some folks were looking at versus just blowing off as just another flu. But a viral pneumonia is serious. It's a serious infection, so you have to look at it from that point of view, number one. So some of the things that you need to do with someone with pneumonia that they may lead to being supported with supplemental oxygen or some more advanced measures and even intubation and taken to the ICU. And some have even used ECMO for some of these patients. But the idea that, this is a serious infection. But this one is kind of unique because of the prevalence of the receptor that it goes after. Yep. So as a result, there are different organ systems that you do see affected by this. And that, for instance, was the cardiac features that we saw early on that we were concerned about. But there are in the endothelium now that that question will go on for some time as we look at the impact of what a venous gas embolism does. We know that it does impact the endothelium. What if it's been injured by COVID, and how long does that take to heal before they're back to normal? So I think those are all great questions.
I think what is safe to say at this point is that, Jim, you mentioned this before, that those early reports where they were very apocalyptic, based on very preliminary data, right, that we have in this study, we know that some people have returned to diving and they're doing fine. So I think it's safe to say that the history of COVID doesn't necessarily mean your diving life, your diving days are over. Great. We still need to know more, but it's not that dark.
Good. All right, next question we have. If I'm in an age group that I'm unlikely to get a serious illness, so presumably this question is from a younger person, should I still get vaccinated?
By all means, yes. Yes, everybody should get vaccinated. Absolutely. Keep in mind that you may say, well, I mean, everybody that is, the vast majority of people that die from COVID are elderly people, so I'm not, so I'm fine. Well, keep in mind that you may be providing the fertile grounds for this virus to mutate, right? RNA viruses like SARS-CoV-2, they mutate a lot. That's why every year we need a new vaccine for the flu. So you don't want to give this virus the chance to mutate, and one of those mutations to render all the vaccines we know useless. Okay, so we have a social and a collective responsibility to make sure that we can minimize the spread and the mutation on this virus that could get us back into deep trouble.
And just bringing that virus to a pristine, remote area that has very limited medical resources. I think we had one where they only had one ventilator for that one area and we're not quite sure whether it was working, but the idea to go to that area and either bring it there or get infected is an issue also. So it's not only self, but it's others. It's the community.
Yeah.
It's the community you're working in.
It's a collective.
If you can, do get vaccinated, please.
Yeah. Right.
That seems to be all the questions we have this evening. Any last words, any final thoughts from you gentlemen? Probably a good spot to wrap up right there. I think you just said it.
Yeah.
Please get vaccinated.
And again, thanks to all our members. The only reason we can do this is because of you. So if you know that someone is not a member, please ask them to keep on collaborating so that we can continue doing what we've been doing so proudly and so responsibly for over 40 years.
Yes, indeed. And we will be coming to you on the third Thursday in July. believe that's the 15th. And we look forward to seeing you then for our next of the monthly 2021 webinars. So thanks again, everybody, for tuning in. We really appreciate you joining us.
Thank you. Good night.